The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric with you. Today what we're going to do is we're going to do another Nightmare Series podcast, and I have Mike Verkest back with us. So we got a great response from Mike being on the podcast. If you haven't listened to that podcast, it was the TXA and traumatic brain injury, the ROC or the ROC study. So check that out. And so like I said, we got a huge response. Everybody really liked Mike. They liked his personality. We got emails from actually Europe and Ireland and Scotland, and so that's pretty cool. So we thought we would do a Nightmare Series podcast, kind of interview style, and so we're real excited about that. I'll let Mike introduce himself again if you haven't heard Mike or heard of Mike, and then we'll start the podcast.
Well, hey, thanks, Eric. I appreciate you inviting me back on here again, and have a great little podcast in store for people. I think it's going to be, I think everybody will be able to relate to what we're going to talk about today. So again, thanks for having me, and thanks for all the emails too. I got quite a few emails, and I really appreciated it. It was really cool.
Well, and Mike, you know, I'm really happy to have you on here. You know, we've wanted to do interview-style podcasts for a while, and I think it's important to have a different mindset, have somebody else's objectivity on the podcast, and I think, you know, we're going to do a lot more of this. And I really enjoy having the interaction between you and I, so that's really cool. So what we're going to do, guys, is we're going to do an interview-style podcast, and Mike is going to lead the podcast. He'll kind of set the stage of what this is. We decided to do a podcast on pediatrics, kind of pediatric resuscitation and pediatric drowning. There's been a lot of drownings in the recent months, and we're starting into the summer months. So we're going to look kind of retroly back to a time approximately 15 years ago, and I'll let Mike kind of set the stage. And then we're going to apply those concepts. We'll talk about the call, and then we're going to apply those concepts to today's evidence-based critical care as far as pediatric resuscitation. So,
Oh, sorry, Eric. I didn't mean to interrupt you. I was just going to say we've come a long way since those days, haven't we?
Oh, absolutely. You know, and I think, you know, there's a lot of things that I think everybody's going to see in this call that there were some huge obstacles. Mm-hmm. So we'll talk about those, and we'll kind of go through, like I said, just a step-by-step resuscitation, talk about the new evidence-based practice. So I'll let Mike set the stage, and then we'll start on the actual meat of the podcast.
All right, so here's the deal. So it is about this time of year. So it was late May, early June, and, you know, getting pediatric calls is something, oh, man, you know, I don't know about you, Eric, but even still today, you know, they're just so tough. We just don't get exposed enough to these kids. And so, you know, when something's bad, you know it's bad. And it's been my experience that they're either, when we get a call for a kid, they're either really sick or they're fine, and it doesn't seem to be anywhere in the middle usually. So we're going to go back to 2001, and you and I were actually working together. And if I'm not mistaken, didn't you come in just for a few hours to cover somebody?
Yeah, I did. I actually came in for a 4-hour block to cover his partner.
Yeah.
And, you know, I've always kind of had that black cloud that follows me everywhere.
Yeah.
And ironically, we were on shift together for about 15 minutes when we popped this call.
All right, so check this out. So we got called out to I don't know if I want to call it rural, but it's kind of on the edge of, you know, suburban rural response. And we had BLS first responders. This was for a 22-month-old child that all the information we had was that it was a drowning. So you and I go in a route. It's about a 15-minute response time?
Yeah, it's quite a ways out.
It's pretty far out. So we get out there, fire department gets on scene, and lo and behold, you would not believe the information that we got and where we found this kid. This kid fell out of a first floor window into a 55-gallon drum that was completely full of old motor oil and water. It was basically the runoff from like when they did their, watered their plants or run off from the roof, and it just sat there and stagnated. This 22-month-old kid fell into that, and we found him. How did we find him, Eric?
If I remember correctly, I believe the grandpa was babysitting. The parents had went into town. The grandpa had actually found him, and the way he fell into the 55-gallon drum is apparently there was a whole bunch of clothes and dirty laundry that was stacked up against a windowsill.
Yep, and he just climbed
right up it. The window was open. It was late spring, early summer, and he just climbed right out the window and fell right in the barrel of oil / water. And the grandpa started searching for him and found him, and I believe he actually carried him out to us. We didn't have to go in the house. Yeah. So we had a very quick response time actually getting access to the child.
Exactly. So there, at this point, there's a lot of things going through our mind. And I know for a fact for me, it's basically when you see that situation where they're holding this limp kid and they're coming at you to give them to you, that changes the game a little bit. And we knew we had a pretty serious call going on our hands. And we had a lot of obstacles for this call. So the first one being transport distance. So our nearest hospital's 25 minutes away. We had very little manpower, and as I recall, I think we were trying to activate the helicopter, but there was none available, or there was something going on that day. Does that sound familiar to you?
Yeah, we had no air backup, and I believe on the fire side we had maybe one person respond, either in a private vehicle and so he wasn't even, I think, medically trained. For some reason, he couldn't even come with us. So we had no manpower as far as the transport goes as well.
Exactly. Yeah, it was a tough situation. So first off, we, from our initial assessment, we can tell this kid's sick, bad sick. The first thing we want to do is get him into our office, if you will, right? Get him in the back of the ambulance and do our primary impression. So first thing we need to be concerned about, obviously, is airway, right? What is going on with this kid? We've got a huge mess on our hands. So what do you recall your initial assessment was when we started doing our primary assessment on this kid?
Well, I want to also add, and I think, Mike, you hit it right on the head, on all the pediatric calls that I've had, whether they've been SIDS or, pediatric cardiac arrest or whatever, it's really, really important to take the child out of the situation and bring him into your office. I think that's the one thing that I always remember is I was taught to grab that child, pick him up, whatever, and get him out into a situation you can control, because obviously that's a very stressful situation for family members. Family members are
absolutely
extremely upset. They're crying. You need to diffuse that situation, get the child into an area that you can control, and that's exactly what we did. And obviously the grandpa helped us in that situation. Sure. If I remember right, the patient was pulseless, was apneic, and we immediately took him into the ambulance and we started compression. So at that point, and I believe we only had to do CPR for maybe a minute or two. We just started getting the BVM out to assist with ventilations, and back then, I don't even remember. The CPR was not 30 to 2. It was
no, certainly not.
I don't even know if it was 15.
It was probably, I don't think it was. It was probably 5 to 1 or 5 to 2, something like that. Yeah. So
I'll let you take it from there. But I believe at that point he did vomit. So we got a pulse back, but then we had a major airway issue.
Yeah, we did have a major airway issue. And the one thing, it's how funny how certain things stand out to you. And in this particular case, I remember the smell of the vomit. It had a very petroleum smell to it. And that's what really alerted us to what the heck did this kid fall into? And that's when we got the information that this thing was full of oil and water. So not only did we have an ingestion, it was clear to me, and probably you, obviously, that he had clearly aspirated some of this as well.
Yeah, absolutely. And I think at this point, you have, if you kind of take this situation and kind of think about it, I know we have a lot of listeners that drive long distances to bases or to their work, and you're listening to this podcast. So put yourself in this situation and think about if you had one partner, that's all you had. You had no helicopter, you had no manpower. Basically, you had to make a decision where you needed to do as much as you could right there on scene, but you also needed to get this patient to a definitive facility. And so that's one of those tough situations at that point, because really, seriously, I needed Mike with me the whole call. And at some point, he had to get us to the hospital. I mean, we couldn't just sit there, all day long, obviously. So,
all right. Well, and and another interesting, scenario that looking back, it didn't really dawn on me, probably because we lived in a smaller community with a community hospital. They were not a specialty ped center by any means or any stretch of the imagination. However, if we would have transported another 45 minutes, we could have got him to a definitive ped center. So looking back, it's like, I think getting him to the community hospital to get stabilized and maybe even flown from there was probably the right idea. But that was just another consideration looking back. It's like, what's the correct call on that one?
Absolutely.
Yeah.
So at this point in the resuscitation, if I remember correctly, we were attempting to deal with the airway. We were assisting ventilations.
Yep.
Obviously recognized really quickly this patient needed to be RSI'd. He kept vomiting. I mean, it was copious amounts of vomit. And so here's where I want to kind of just, obviously we're still dealing with airway, but we know in the critical care environment, and I know a lot of listeners, if you're ground-based paramedics, not all counties, not all states allow paramedics to RSI. Mm-hmm. Fortunately for me and for Mike, I've RSI'd from the time I came out of paramedic school. Oregon is very progressive, and for everywhere we worked in Oregon, we were expected to have that standard, and we all RSI'd right out of school. That was part of all the county protocols. I mean, I can't remember of any agencies that didn't RSI. So we immediately made that decision. This patient needed to be RSI'd. The airway needed to be managed and maintained and protected.
Yeah.
So, but what do you do with that situation? You don't have an IV access. And this is where I really pound this into people is, the adage of establishing an IV on a pediatric or even an adult. Now, even nowadays, when we have the IO capabilities that we do now compared to back then, the whole 3 attempts in 90 seconds is absolutely hogwash. I mean, you're not going to get 2 or 3 attempts in 90 seconds. So now that I've flown for 12 years, I realize if I get on a patient and they're critical, I don't even worry about a peripheral IV, especially if I see that it's going to delay anything. And we immediately recognize this. Now, this was back, guys, where we had to actually screw the these were the blue top. I don't even remember what they're called.
They were called jamsheeties.
Yeah, and so we were having to, do this, and each of us established an IO. I believe Mike did the first one. And I said, well, heck, I'm just going to do another one. I wanted a second IV access at some station.
So basically, we'll just pause right here because I think it's important to talk about what's going on for the pathophysiology of that lung, right? So I think if Eric, so why don't we talk a little bit about these drownings and we always hear dry drowning, wet drowning, add the petroleum onto this one here. So there's a lot of metabolic things that are going to happen. Hypoxia, it's a big deal. We can talk a little bit about freshwater, saltwater drowning, those kind of things. So why don't you kind of explain to the listeners and give us just an idea of that pathophysiology?
Okay. Well, when we look at drowning, I mean, ideally, you're most often probably going to have a freshwater drowning. I mean, obviously, if you live on the coast, you could obviously have a saltwater drowning. But so we'll kind of classify each one of them. The things to remember, though, is they say that you'll have that mammalian gag reflex and you'll have the laryngeal spasms. That only happens about 10 to 15% of the time. So most drownings are actually wet drownings, 85 to 90%. Both of these, though, however, will lead to a metabolic acidosis, profound hypoxia. And that's secondary, obviously, to anaerobic metabolism that starts building CO2. We have hypoventilation. We're starting to build CO2. We know CO2 is a strong acid. It drives our pH down. And so it's going to lead to that metabolic acidosis and that profound hypoxia. In a freshwater drowning, the things we have to remember is you have a huge amount of water that's flooding the lung area, those interstitial spaces, the alveoli, and it's actually causing surfactant washout. If we don't have surfactant and we have washout, we don't have any diffusion or our diffusion-perfusion gradient shunt there starts getting bigger and bigger and bigger, you're going to have alveolar collapse. You're going to have nitrogen washout. You're going to have alveolar collapse. So you have a big issue there because of that. So essentially you're dealing with a patient like we would see in ARDS, where you have a huge amount of volume in between the alveolar capillary membrane. You have surfactant that's been washed out. You have no alveolar PEEP, so you have trauma, atelectasis trauma. So these patients need to be placed on a transport ventilator. They need to be dealt with high amounts of PEEP, aggressive PEEP. So the big point is to deal with maintaining alveolar recruitment. So, dealing with a tidal volume that's physiologic and then maintaining a PEEP that's going to maintain alveolar recruitment throughout the whole exhalation process. That's the big deal. We got to make sure that we move through any shunt that is happening based on all that water, all that gunk that's now flooded those alveolar spaces. When we compare that to an actual saltwater drowning, we have a phenomenon called a hyperosmolar shift. And this is no different than we see in a patient where we give a hypertonic fluid. We just did a podcast on fluidology. So it's going to be the same concept where we have a hypertonic fluid. So remember, in that situation, you have higher amounts of solutes that are outside the cell. So water is always going to follow the solutes. It's going to move from the cell outside the cell, and your cells are going to shrink. Well, in this situation, you're going to be third spacing blood, plasma into the pulmonary spaces. You don't necessarily have surfactant that's being washed out, but now you have, again, a phenomenon real similar to ARDS. So you have a big diffusion gradient shunt, and you're going to be dealing with that in the same way with high amounts of PEEP and aggressive alveolar recruitment. Yeah. With this patient, you kind of had, I guess, both. I don't really know what the petroleum, if that would have caused any hyperosmolar shifting. Honestly, I don't know that answer. But you definitely have the surfactant washout, and you have the issue of potential pulmonary shifts with blood and plasma. On top of things, you also have all that stuff that's now in the gastric area, in the stomach, that we're having to deal with as well. Yeah. So, we have two different kind of thought processes. Again, you're going to be dealing with those thought processes on the critical care level with the ventilator. Obviously, first is airway management, and then you have to be thinking about how you're going to maintain the best alveolar recruitment and the best oxygenation possible, because that's truly what's going to help the patient.
Exactly. So that brings up a good point. So let's say we had this call today. Let's say you flew in, landed, and you were presented with a situation. What kind of ventilation modes would you be using? What kind of things, what kind of tools do you have in the critical care arena that you'd be able to manage this patient's airway and breathing on that critical care level?
Well, there's a couple ways you can go. Again, if the patient becomes responsive somewhat, let's say you aren't able to get them intubated for whatever reason, but they are somewhat semi-responsive. There are programs out there that have the capability of using CPAP or BiPAP, and BiPAP would be my preferred choice to maintain a higher mean airway pressure, maintain a good alveolar recruitment, and make sure that functional residual capacity. Remember, that is the amount of air that's filled into the lung spaces as high as possible. So BiPAP would definitely be a possibility. Obviously, that's probably not going to be attainable by most programs, and so for me, and what I would do is I would go straight to either pressure control ventilation, SIMV, so I'd use SIMV, pressure control ventilation, or pressure regulated volume control, which is PRVC. And the PRVC we know is in the transport environment specific to the Ravel ventilator. Those would be the modes I would go to as far as delivery, because we know that pressure control, or any time we deliver a breath via pressure, you have a decelerating flow pattern, which causes a better decrease in shunt. You have better continuous oxygenation potential. It's just much better on your patient. And then it's a compliance-based mode. So we know that their lungs, especially in pediatrics, are baby lungs. And these baby lungs are now injured. Obviously, the kid just drowned. And so we have to be very, very careful of any barotrauma. And so pressure is obviously the go-to mode in the transport environment. There are ventilators now in the hospital environment that are $50,000, $60,000, $100,000 that can be very, very good in volume modes, but we don't have that capability in the transport environment. So we have to go with pressure in these pediatrics. So I would identify immediately pressure control ventilation, and I would continue in that arena.
Okay, so as I recall, that the secondary assessment, once we were on, once we had things going, and when we thought we had our airway secured, the secondary assessment was pretty good. He didn't have any trauma. There was nothing weird going. We didn't suspect any kind of abuse or anything like that. But I remember we kept having trouble with the airway. We had the airway, then we didn't have the airway. Then he'd throw up, and we'd lose the airway. So talk to me a little bit. I remember, like it was the back of my hand, Eric, that how frustrating this was for you, because once I was going to drive the ambulance to the hospital, you didn't have any help. You were completely by yourself.
Yeah, absolutely. I still, you look back on different calls in your career, and this was 15 years ago, 14 years ago, and I still remember this very vividly. That for those of you out there, listener, Mike at that point was in paramedic school. He was an outstanding intermediate. I mean, he really was, and there wasn't really any difference as far as a paramedic and intermediate, as far as I was concerned, with him in the back of the ambulance with me. I mean, I felt like there was no difference, and so his help, his understanding of medicine was huge. And at some point, like I said, you have to make the decision, all right, it's time to transport. And so my recollection is we got him, I intubated him, and back then we didn't have cuffed ET tubes for pediatrics.
Nope.
That's, you got to remember, that's something that's just happened in the last 5 to 8 years. That's not something that was 15 years ago. So, it was very, very easy to extubate a patient like that. And I remember getting him intubated and saying, all right, let's get going. And immediately start going. And like Mike said, we had a 25 to 30-minute transport going emergency traffic from out, on rural roads, windy roads. And I remember every time I would get him intubated, he would vomit. So I'm having to keep him oxygenated, attempt to suction him, and then continue to intubate him. And again, then I was starting to question our IO. And if I remember right, I was pushing medications through one IO.
That's right.
And realized that one of the IOs was bad and
That's
had
right.
to go to the second IO. And I think finally when I realized that first IO was bad, went to the second IO, started pushing the drugs, the vomiting stopped, and I finally got him intubated and his airway secure. But that's a very, very frustrating situation because we're taught airway is number one. But I definitely couldn't even ventilate him because he kept vomiting. It just kept pouring out. It was almost like pulmonary edema coming up, essentially.
Yeah.
Maybe it wasn't actively vomiting, but there was constant volumes of fluid coming back up.
Yeah, and one more thing I might add, again, remember, we're 14, 15 years ago, there was no end-tidal CO2. So we, in a pulse ox on a kid, everybody knows how that goes, right? On the ground side of things, you try to get it on their toe or whatever, it just wasn't happening. So if there is a case that's called the nightmare case, that was this one. I mean, it fits into this perfect because it was nothing but a nightmare. So I'll talk a little bit about, as you recall, the ride in, other than dealing with their airway. I mean, as I recall, it seems like we were probably just a few minutes out before you actually we had a patent airway. Would you agree with that?
Yeah, I remember actually, telling you, you gave the radio report. I still didn't have the airway at that point, and then we tried to give that within 10 minutes out. And I believe probably 3 minutes out before I actually got the airway secured with an actual commercial device and started bagging him and starting to think about our secondary medications as far as sedation and fluid replacement. I mean, I really never got past airway on this child.
Okay, so when we talk about RSI medications, back in the day, it was Versed, and it was Sux, and it was Vec, and that was all we had. So if you contrast the drugs we had then versus the drugs we have now, I can think of a lot, better set of medications that would have done this kid probably a little bit good. So we talk about ketamine, perhaps some fentanyl, although we kind of ran out of time, and maybe even rock. So maybe talk a little bit about the contrast between now and then as far as those medications go.
One of the things we have to remember is the medications now are much, much different. We have a huge amount of different tools that we can put in our tool bag compared to back then. And back then, like Mike said, it was Versed, it was succinylcholine, and it was Vec. And I believe the Versed dose back then for pediatrics was something like 0.02 milligrams per kilogram, weight-based. And so, we gave this kid the Versed, and then we went right to succinylcholine. Based on our other podcasts that we've done, we know that succinylcholine has a concept based on the mechanism of the medication. It causes a desaturation much, much quicker because of the fasciculations and the muscle firing than rock does. And I believe the studies showed that it caused a patient to desat 2 minutes quicker than using rock. And one of the arguments you have to look at between paralytics, and I've had this discussion with some top people in HIMSS around the country, and when I explain it in this way, if I gave you 3 different vials and I taped those vials so you couldn't see what they were, right? You didn't know if it was sucks, you didn't know if it was rock, you didn't know if it was VEC. Would you deal with that airway any differently? And I would argue you would not. You're going to go through all your equipment checks. You're going to make sure your suction's there. You have a backup airway. You're going to make sure all those things are in place. You're going to go through your first attempt. If you have a failed attempt, you're going to change something. You're going to go through all the different things that we've learned. Once you change something, you have another failed attempt. At that point, you can pass it off to another crew member that is trained. And then at that point, if there's a failed attempt, you go to a backup airway. And you're going to do this whether you give sucks, whether you give rock, or whether you give VEC. We don't ever let somebody sit there with no definitive airway. And so even though a king airway isn't a true definitive airway, it doesn't protect the airway as perfectly as an ET tube, it's still a backup airway, and it's something that we would place no matter if we missed with sucks, VEC, or rock. The argument of not wanting to give an intermediate paralytic like rock, or for that matter VEC, in a induction situation like this is wrong. So I've used rock for RSIing patients many, many times. There was a shortage in succinylcholine in this area, maybe throughout the whole country, about 4 years ago, and we used rock for our first-line paralytic for over a year. And so, again, that's what really made me look at that and say, I didn't do anything different. I'm still going to do the same exact things. We train on airway until we're blue in the face. And so when I look back at that now, this patient probably would have benefited more with giving rock. The succinylcholine aspect, we could have given a defasciculating dose, but again, you don't have the help there.
We had to get going.
Yeah, absolutely. So I think that's a big, big deal. And so I think when you look at that, from the sedation side of things, I think ketamine would have been a perfect medication because
absolutely, ketamine
is a medication that would given you a bump in blood pressure, bump in heart rate, and it would have also given you some beta-2 bronchodilation. So that's really, really good. And we know as far as pediatrics go, heart rate is everything. Heart rate and stroke volume equals cardiac output. And these kids have to have the heart rate. And obviously he was already in arrest. He's going to be profoundly hypoxic. His heart rate is going to be driven off that hypoxia. So anything we can do to bump that heart rate up is going to be a positive thing. So looking back on that, I think ketamine would have been my ideal choice. Nobody would have been wrong to give a little bit of fentanyl prior to the ketamine if you felt like you had time. But again, in this situation, I think this is a serious situation where it's almost a crash airway situation. So ketamine, probably rock would have been a better choice. And then, again, like you said, we used to just give VEC and we'd give maybe another dose of Versed. And that whole mindset has absolutely changed, right? We know now that we don't paralyze patients long-acting unless we absolutely have to. We always treat the pain with a analgesic like fentanyl primarily, and then we give small aliquots of benzos, either Versed, Valium, or Ativan based on the age of the child. Now, Ativan is probably the best medication for a kid, so that would have been another option.
Hey, one thing that I think we would be remiss in if we didn't mention, and that was the use of some kind of a length-based guide or weight-based guide for all of our pediatric decisions, whether it was medication doses, ET tube sizes. So for those of you that are out there listening, if you don't have some type of a weight-based or length-based guide, so you don't have to remember stuff, that's really going to be good for your patient care, because I got to tell you, we have to remember so much stuff as it is. There's no reason why you should have to commit a lot of these pediatric doses to memory. Always run these doses by another person to make sure you're not going to have a medication error. So, I mean, as a huge patient safety advocate, I just felt felt like I would be remiss if we didn't mention that. So I do know that we had that length-based tape out. We were using it quite actively.
Absolutely. The Brasilo tape is the primary one. And, most of the charting programs, and I know most of the companies that I've dealt with or work with currently use the Brasilo tape, and that has to be documented. You always document the color, things like that. I think that's one of the things that I still do. I still carry a field guide in my pocket. It's the same exact field guide that I've carried for 15 years. It's out of date in a lot of circumstances, but I use it for a few reasons. And the primary reason I carry it is some of the drips that we do, and primarily for pediatric stuff. If I know I'm going on a pediatric call or a pediatric flight, that's one thing I always do. I pull out that field guide. I look at it really quickly. I want to know what the normal heart rate is, what the kilograms are for that patient, and I want to know the ET tube size. Those are the three big things that I want to worry about. I can do everything else pretty much in my head as far as calculations go, and obviously you're gonna verify your drug dosages and things like that with your Brasilo tape. But those are the three things I want to know, and it's really good to just refresh you. It kind of gets you in that mode, and then you get on scene and you don't even miss a beat.
Yep, absolutely. And one last thing, that if we would have had the world as our oyster on this call and we had all the people and all the time, it would have been great to put an NG tube or something, or an OG tube down this kid to help kind of alleviate some. I mean, he was doing pretty good on emptying his contents himself, but it would have been nice if we would have been able to assist with that a little bit,
Absolutely. One of the things that we have to always think about, and it's a big issue, and it's a big issue industry-wide. I think from QA and charts to teaching around the country, this is something we forget. We all forget. I forget. We have to always put an NG or OG tube down. Every intubated patient needs an NG or OG tube. Some things that I hear, don't ever withhold an NG tube because the patient has a head injury. Don't say, well, this is going to increase ICP. That's absolutely hogwash. If you're dealing with a pain, these patients are intubated, you're dealing with the pain appropriately, it's not going to cause an increase in ICP. You need to put the NG tube down. The risk for aspiration, the risk for VAP, ventilator-associated pneumonia, is a big deal. Aspiration in of itself increases mortality 50%, so we have to really worry about getting that NG or OG tube down. And in pediatric patients, we have to understand that any amount of gastric contents or air can cause a huge issue, and it almost acts like a hiatal hernia. It compresses on the diaphragm, compresses on the great vessels, the heart, and it's really going to impede your cardiac output. So we have to always be cognizant of putting an NG or OG tube on every intubated patient, but specifically pediatric patients. That's a big teaching point.
Yeah, absolutely. And that is a huge thing. And, and on the ground side of things, I see the same exact thing. It's just something that, it just gets glossed over. And, a lot of times there's not particularly time to do that extra thing. But it sure can make for better patient care ultimately if we can get that done.
I agree. I think looking back retrospectively, I think I know we didn't put an OG tube down. I think we rolled into the hospital. I had just secured that ET tube, and we rolled in. We had the IOs established, and at that point, we handed off the patient to the team there at Three Rivers Community Hospital. Just for listeners out there, the patient was flown by fixed wing a few hours later to Portland, to the Children's Hospital up there, to Emmanuel. And he did survive. It was a surviving thing. So that was a really good thing for us, because I can say that out of all the calls I've ran in my whole career, that's one of the calls I look back where I felt stressed. And usually, if you've worked with me, I stay really calm. I don't get worked up. But that's one of the calls I remember being very frustrated, where I felt like I couldn't control what was going on. And it all had to do with that airway. That airway was not going my way.
Yep, absolutely. Yeah. Add up all the other things. Lack of personnel. It was a really terrible airway. It was, distance, time, no air support. I mean, it was like everything that could go sideways was going sideways on that call. So, but you know what? Ultimately, the patient had a good outcome. I recall that he was in the PEDS ICU up at Dornbecker for probably about 6 weeks. Ultimately came home and it was doing fine with no real deficits. So it was a happy ending to what was truly a nightmare call.
Absolutely. I just want to add one more thing. One of the things that we teach on and I've hounded on is passive oxygenation. And I remember having a non-rebreather out, and it was right up against the patient, and I had the BVM out, and I was attempting to ventilate him, and I felt like I was maintaining his skin color was pink throughout the transport. Obviously, I wasn't continually attempting intubation with a hypoxic kid, or he probably wouldn't have survived. But one of the things I could have done, based on what we know now, is just even a simple nasal cannula. And this is a really good teaching point in kids, is a nasal cannula at even 6 to 8 liters per minute is excellent in passive oxygenation, the whole aspect of Graham's law and diffusion, but it also adds PEEP. And just that nasal cannula in a kid like that adds a great amount of PEEP, and it maintains that alveolar recruitment just based on the nasal cannula. So don't forget that. That's a great tool to use, and you don't ever have to take it off. Even if you have an intubated patient, you keep that nasal cannula on through the whole process, through
Absolutely.
the intubation and all that.
Yep.
So that's a kind of my last point.
Yeah, but you were ahead of your time back then.
Well, I don't I don't remember doing the cannula back then, but
well, you probably did, but you had that non-rebreather and it was going, so
Yeah.
close enough. Yeah.
Well, so that's all we have, guys. I think hopefully you enjoyed this podcast. It was it's a little long, but I think we've covered a lot of things. I think one of the things I do want to add again, and I keep saying this over and over, we have to be really good about and aggressive with our fluid resuscitation. One of the classes I teach, I think it's one of the best classes out there, is called Pediatric Fundamentals of Critical Care Support. And one of the things I learned when I was learning to be an instructor for that course is that all the studies show we're very poor at volume resuscitation for our kids. We're taught 20 mils per kilo, but oftentimes we stop after one bolus. And so one of the things that they teach, and this is an accepted thing in emergency medicine around the world, is you give volume on these kids until two things happen, or one of two things happen. Either you cause them to go into pulmonary edema. Obviously, in this situation, this kid wouldn't have done well in that. Or you cause liver enlargement, so hepatomegaly. Those are the two stopping points, because they can draw that fluid off. They can draw that water off. The kid is going to be able to handle that. And obviously, that is an excessive kind of demonstration, but that is truly what they teach. They have you teach that because we do such a poor job at volume resuscitation. So remember, 20 mils per kilo, 20 mils per kilo, 20 mils per kilo. Don't just stop at that 60 mils per kilo point. If your patient is still not responding, their heart rate is still not maintaining, you have all the oxygenation aspect fixed, you continue to give more. Don't stop. These kids can handle the volume.
Awesome. Cool. Well, hey, Eric, it was a great review of that case, boy, so long ago.
Yeah, hey, I really appreciate it. And again, guys, send us your emails. Give us, if you have any topics, anything you want to cover. We plan on doing some other cool interview-style podcasts between us. We've got some really neat ideas. One of the things to be looking at, really excited about, is we are developing a critical care resuscitation course that's based on the pre-hospital provider. So we're developing a course that's going to be a 2-day course. We're currently writing the book on it right now. It's going to completely be focused on evidence-based medicine. We're going to discuss evidence-based medicine and how it applies to critical care ground and HIMSS. And we really think that there's nothing out there like this. It's going to be kind of tailored like AMLS, kind of that mindset, really short lectures, great breakout sessions. So we're really excited about that. So be looking for that. We'll be talking about that quite a bit in the next probably 6 to 9 months. And we really thank everybody for listening. And I want to thank Mike again for taking the time out of his evening with his family to sit down with me and kind of rehash one of our old calls.
Absolutely.
And again, shoot us your emails. We thank you so much for following FlightBridgeED. We're nothing without you guys. And we will talk to you soon.
See ya.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.